edema. And Tom is the person that I talked to you about before, who had given up on his treatment. He had gone into hospice. He had over $100,000 of medical bills, and he didn't know what to do. He said he couldn't afford to live. And Tammy worked with him until they wrote down those medical bills, got him on a payment plan, and got him back into treatment, and he has been with no evidence of disease for 3 years. So this is an unbelievably heroic and activity, and they are tenacious, persistent, and extraordinarily creative. So I just want everybody to join me in giving them both a huge hand. And I also want to tell you, we're going to send you the link to Rita's story on our YouTube. She told me this morning, the Children Mother, she was on YouTube, about helping an elderly woman resolve things the issues were more than just money, and they were more than just trying to get food, which happened to be for her dog, but they were about loneliness and isolation, which is a really significant problem when one is ill or when one is a caregiver of somebody who's ill, as Rebecca spoke about. And then you see up there Tammy Taylor and Shirley Bridgette, and that is from our policy consortium about talking about cost of care, conversations about cost of care. And we are doing in March a workshop with Tammy in the Delta, in the Mississippi Delta, on looking at rural health issues through the lens of cardiovascular disease and obesity. So I'll stay tuned to that. So this panel, one of the things I wanted to do was was to talk to you, and not just tell you, but also have the advocates that we've worked with tell you about our experience trying to weave people through and amplify their voices in everything that we do. And everybody who's on this panel, the first stories that we heard from them, I have to say, actually, that's not true with Sabrina, because Sabrina came to the North Carolina workshop, but they came through our Story Slam last year. And the person who's missing here is Susan Brown. But we have been doing now it's a 2-year line where we're just doing some more work. Robert Wood Johnson Foundation funded project on conversations about cost of care. And the foundation funded research projects on the cost of care. There were 2 streams, one about integrating cost of care conversations in clinical work streams, and that was one of Susan spoke about that in her webinar, and the other was about dealing with vulnerable populations. So part of what we did with that is that we did a series of webinars, and in each webinar we asked, Jamie was the project lead on that, Jamie asked one of our advocates to pair up with, whether it was a clinician, Shanta did it, or Shanta is a clinician by training, but Shanta did one of the workshops, one of the webinars. We paired one of our advocates with somebody else to talk about issues. So I wanted to just show you how this engagement with us does not end at Policy Consortium, and we also take what we learn from you and bring that out into a wider audience, and we hope that we all learn from each other and really create this kind of incredible community of learning, of solutions, of listening, of action, and of advocacy. And we were talking yesterday at dinner, a few of us, the people in our team went out for dinner. We talked about the difference between supporting and advocating. And we want to get to that point. We don't want to say, oh, I support your bill. Oh, I support your, right to do this or that. We want to advocate for the people who, whether it's on a community level, an individual level, a regional level, or a national level. So this is part of what I want to talk about here. So this is just one example. There are multiple examples, and you'll see them as we go through the day and as you hear other panel presentations. But I asked the advocates who were on who participated in our webinar series to just talk a little bit about what they, very briefly talk about what they brought in their lived experience and how they made that relationship between their personal experience, which is what we're looking at in our story slam, and larger advocacy actions and things that resonated with a larger group than just a personal story. So I want to start with Rebecca. Rebecca Barnes talked about the patient and caregiver roles in conversations of cost of care, and Rebecca's partner in this conversation was somebody from the National Caregiver Alliance.
I'm trying to think of the best way. Sorry, I'm a little nervous, but
that's okay. So, well, I guess maybe Rebecca, one of the things. So, what do you think? If you were thinking about some of the messages that you delivered through this webinar, if you could just share with everybody a couple of the lessons that you shared with people on the webinar based on your lived experience as a caregiver and as a patient.
Sure. I did help take care of my sister. She was 8 years younger than me. She's from rural eastern Kentucky, so she had to travel pretty far for her chemotherapy treatments, radiation treatments, stem cell treatments. I ended up moving to Lexington, and it was just easier for me. My mother, she ended up having to take early retirement, so she had to pay for that to take those years off. Then my dad was the only one working. He was a banker, so he made middle income. And just the cost of care didn't just include her care, it included the hotel rooms that they had to stay at all of that time, the gas that they needed back and forth, food that they needed, whether it be, a lot of the times they may not have a kitchen in their room because they were going the cheap route, so they had to eat out. So there's a whole lot more to cost of care than simply, having to pay for your medical bills. But not only that, being on my mom's insurance and then switching over to, state medical care was very difficult. They're like, okay, we're going to pay for ABC, but we're not going to pay for D. And then it was like, okay, the only way that she's going to live is through a stem cell transplant. And then they didn't want to pay for it. And so it was a constant with, calling insurance company, having the doctor call, us calling back and forth, and then me as her sister calling with permission of my sister to call on her behalf because, she's sick and now she's over the age of 18, and having an advocate for her, but having an advocate for my parents because, there's a lot of emotions that go on with that, and at some point, after 4 years of doing this, you get exhausted, and so, and that's just like, that is my sister's story. But then, come to find out I've been doing patient advocacy, and now at this point, I have a medical issue. They don't know what it is, and so it's been dealing with multiple doctors, and now I live in Kentucky, but I go to Florida for my treatments. I just got a port a couple of months ago, and so, the new doctor is like, okay, we decided we're not going to do this. Then the insurance company, they don't want to do that. And there's so many different issues that go along with care, and people just don't understand that it's on so many different levels. And, it's a mind, body, spirit type of thing. And like when my sister went to the hospital to have her chemotherapy, she wasn't given a nutritionist, she wasn't given a dietitian, she wasn't offered any type of spiritual care. My parents weren't brought aside like, what can we do for you, as a person? And you can't just take care of one part of a person, right. It's everything. And when you just do one thing, then you can literally see someone's, health just deteriorate. And the financial aspect is huge, and people actually will give up the will to live because they feel as if they're a burden to their family and the guilt that they have of being sick, and it's not talked about. And so, coming to National Patient Advocacy, I was looking after my sister passed away, what can I do, because I just feel so lost. So I ended up being a co-event coordinator for the Leukemia and Lymphoma Society, and I did that, but I still didn't feel like I was doing enough. And I searched and searched and found you guys, and that's how I was able to be here. and speak my voice, and then end up having issues that I'm dealing with, and other people that I now meet on the hematology oncology floor that I'm like, okay, yes, I can help you. I can, there are people that will help you, and that's the one main issue is you see a lot of seniors that come through that don't have families. They're driving themselves to their chemotherapy appointments, and they are just, they don't have anyone, and they don't really speak up for themselves. I spoke with Donna about this. There was a lady that had went into the hospital and come to find out she was diagnosed with breast cancer. Well, they didn't tell her exactly what was going on. They said, you have a doctor's appointment tomorrow. This is where you need to be. And as I was getting my iron infusion, they sat her down beside of me, and they were like, you're going to have nausea. These are the things that are going to happen. And she looks very confused. And she's like, what's going on? And they're like, well, for your cancer. Well, she didn't know. And she starts crying. Her husband's with her. And I'm just lost. And the nurse was very not empathetic to her. That I know, that's how my face was too. I'm like, how is this happening? And I reached out to her, and I'm just like, if you need anything, I'm here for the next couple of hours. But, people need to understand that it affects everyone. The nurses are overworked, underpaid, the doctors and nurses that don't talk, the insurance companies that are the ones who are now determining what type of medication that you need. And, I'm here to do whatever I can to do to speak on their voices, because they don't really, they're sometimes too sick to voice how they feel. So.
And I think the other thing, I remember one of the things you said at the webinar that really struck me, which was that your parents were struggling to pay for housing. You were struggling to pay for housing,
right.
And there was a program at the hospital that would have helped pay for
right.
pay for housing. So this is one of sort of the basic foundations of being an advocate and being a self-advocate. But if you don't know, how did you found this out
after she passed away? So basically, I got a job at the hospital my sister had her chemotherapy through 2 months after she passed away, and I was talking to one of my friends that worked there, and I was like, there really needs to be a program here to help people, to direct them to where they can get gas cards or food cards or hotel rooms or, rental assistance, mortgage assistance. And they're like, oh, well, we actually have this piece of paper here, and there's some, resources available. And I'm like, well, why don't you all hand it out? And they're like, well, we can't help everybody out. If they really need it, they'll ask for it.
So this is one of the, this is one of the things that is part of the project that we're doing, which is to normalize foster care conversations and have them integrated into the clinical workflow and the patient life flow. And so one of the actually I have to say the big contributions that we made to this, which seems very simple, but it was not there, was to make sure that we added in not just clinical workflow, but also the patient life flow. Because these two things go together. And there is this idea that cost of care conversations take a long time, but in fact they take less than 5 minutes, unless there's something really complex. And if you don't have them in the beginning, they are more and more and more complex, and they take more and more time, as we've heard talked about earlier in this session. Sabrina. So Sabrina and I met, we met at Patient Congress, but
yes.
Then we met again when I asked her to come to a workshop we were doing in North Carolina with the Mountain Area Health Education Center. And Sabrina told, and as those of you who are at Patient Congress might remember last year, Sabrina is just a riveting storyteller.
Thank you.
She is a riveting storyteller. So I asked Sabrina to be Sabrina was on a webinar with Shanta. Sabrina and Shanta were partnered to talk about special needs and issues that are faced by vulnerable populations. And Sabrina's told this incredible story that then we asked her to turn into a blog on our website. Now I'm telling you some of these things just so you see, you see what these different opportunities are and how we hope to continue to keep on growing the way that we work with you and work with our advocates and bring your voices in. But Sabrina, can you tell the top level of this story? Yeah.
I can. And yes, because we're talking about cost of care, my cost of care story came from the point of not being able to afford my insurance premiums, and as a mother of 5 children, I had to make the devastating decision one day to pay my car insurance premium, but then I look at my kids and I'm like, I don't value my car more than I value my children's health. And so the biggest part of it all was the anxiety and guilt that I felt, because I remember driving off from the car insurance company and I was at a light and I felt like if I just drive through this light, like the car won't need insurance, me and my kids won't need insurance. But that was the burden. No, I wasn't suicidal. Let me put that out there. I wasn't suicidal and I wouldn't have done that. But that's how heavy the burden was on me, because I had to make that decision. And just knowing that patients are facing this burden of cost of care and carrying the anxiety of how they have to distribute funds in their household, this is really a very important subject for us to advocate on patients' behalf.
And I think, one of the other things that happened was that I heard this story because the president or the CEO of the Mountain Area Health Education Center of the organization said to Sabrina, we were having dinner the night before the workshop, and he said to her, "What made you become an advocate?" And this is a story that she told. And it's a story I will never forget. And it also is a story that I won't forget on the other side, because here was a hospital administrator who actually asked the question, what made you become an advocate? And he listened to your answer. And so there's a lot of people say, I hear you, and to me that's really the most placating, condescending thing to say to somebody. I hear what you're saying. But if you listen to what somebody says, you can actually affect change. And that's what he did, and that's what you did. And then you went out and got a job and got insurance and became an advocate. So
Yeah.
what are the actions that came out of that story?
So the actions that came out of the story, the good part, I did secure a job, and I'm still there. We have great insurance. However, I still work with patients, and when I hear about the barriers that patients face when they're trying to get their medications, I not only hear them, but I hear and understand what they're going through. And so one day I had talked to my manager and said, look, this is not fair. We have to do something. Somebody has to do something. And she said, well, you do something. Well, so I go back to my desk and Google and look up advocacy, patient advocacy, and that's when I found National Patient Advocate Foundation. And at that point, I knew the first time when I came to Patient Congress and I was standing on Capitol Hill looking like, oh, I am going to do something. Like, oh, this is real. So that fueled my passion to exude a stronger voice of representation for patients.
Great. Yay to both of you. So before I turn to Cynthia, I want to do one follow-up question with Rebecca. So how many people in this room who have been advocates for a long time, when something happened to them or their family, their advocacy skills just flew out the window? So imagine all of us, some of you are newer to advocacy, some of you are not. Imagine our capacity for advocacy and how it can just fly out the window when we're faced with something for ourselves. And I was just, when you told your story about your sister and advocating for her and how your entire family came together, you needed your entire family to come together. Do you think that any one of you could have done it by yourself?
No, there's no way. No.
Yeah.
And I mean, it took everybody because, you know, mom quitting, being able to be, you know, sole caregiver, and then my dad being sole financial, you know, and me being there as an advocate and supporting and, you know, working together as a family, and then having other family members back home to look after the pets in the house, and, you know, so.
Yeah, I mean, and one of the things, I mean, I'll just ask Rita and Tammy if they want to say anything about this, but one of the conditions, one of the facts about the patients that we serve at the Patient Advocate Foundation is that the majority of them are in very small household sizes. The average is 2 people in a household, isn't it? And their average income is $35,000 or below. So imagine not having that kind of support. And that is one of the reasons why it's so critical that we all do what we do on whatever level that we do it. I will tell you, when a number of years ago, my mother had a life-threatening infection. She ended up in the emergency room. I was in the emergency room with her. I had been doing advocacy for 10 years at that point. I completely forgot until 2 weeks after I left the hospital that I knew the patient advocate who was the patient advocate in that emergency room. I had spoken in her class, and I completely forgot about this because I was so overwhelmed with this, with what was happening to my mother, the fact that my mother could have died of this infection. It was Columbus Day weekend. I mean, all of these things were happening, and I completely forgot that I actually could go to somebody for this. So imagine that nobody gives you the information like the hospital didn't, and imagine that there aren't people like the people that that all of these people are sitting in the room who are advocating on the behalf of others.
Yeah, I felt like we were very lucky. Even though we didn't have a lot, I still felt that we were very lucky because when you go through those treatments in the hospital and you live there, you make friends with the other family members. You become close with them as well. And, you know, there were family members that were living in their cars outside in the parking lot, and there were family members that were living on the yogurt and bananas, the free stuff that the family kitchen had, you know, so.
Which is completely unacceptable.
Rural Eastern Kentucky, so
Yeah.
rural areas,
Yeah.
you know,
Yeah.
and everybody wants their family to be there, so, yeah.
So Cynthia was on the, so one of the projects we've been working on in one of our care lines is about access to precision and genomic medicine, genomic and genetic testing, and access to precision medicine. And one of our goals is, everything we do is about closing gaps. It's about closing gaps between discovery and delivery. It's about closing gaps between insured and non-insured, closing gaps between our ability to pay for our cost of care and our cost of daily living. So one of the projects we've been working on with the National Human Genome Research Institute, which is part of the National Institutes of Health, is looking at access to precision and genomic medicine. And Cynthia was on and a lot of these diseases, a lot of this is cancer, and a lot of these diseases are also rare diseases. And Cynthia was on a panel with my friend and colleague Carla Easter, who is the head of who is the branch chief for education and community involvement at the National Human Genome Research Institute. And Cynthia, as most of you know, has been caretaker for her daughter with a rare disease. So Cynthia, just on a sort of, if you could just give us a few high-level tips of how you would help. You had to advocate for your daughter. When you're in a community where there's a rare disease, and our friend Mike is now in that community as well, there isn't that support that you have if you're, I mean, not that I'm going to make one diagnosis better than the other, having cancer 3 times. It's really not anything I would ever wish on anybody, but there is a community in the community of cancer survivors. There's a community in other kinds of diseases that have a higher prevalence. But when you're in a when you're in a place where there really is no community, or there's a very small community because it's quite rare, you have to learn your advocacy skills really quickly. So if you were talking to somebody whose child or partner or any family member had a rare disease, what would be, let's say, the 3 things you would tell them that you found the most helpful and the most necessary to successful advocacy?
Educate yourself and become more of an expert than the doctors. Okay, that's one. Develop your network and talk to them regularly, but you have to really think about how you talk to them, because you don't want to overwhelm them and you don't want to say stupid things. And I say that because in my daughter's case, there's no treatment and no cure, and the disease progresses to liver failure in 10 to 12 years. But then I found a cure, or a treatment, not a cure. But the medical community doesn't accept it. And so you have to become the expert. And my biggest challenge after my daughter is now doing fine, you'll hear more about that tomorrow, but my biggest challenge was then understanding that no other patients had access to this, and they had no options. And so how do I get that to them? So I'm a Facebook blogger. All I do is talk to PSC patients, much to the horror of my family. At any hour of the night, I have them in Russia, in Taiwan, in Saudi Arabia, but I have to educate them, and I have to, and that was my next challenge. How do I educate these patients without repeating myself interminably? It was just, and I just think nobody on the internet, when they see my name, they're like, oh Lord, do I have to hear this again? And so I wrote papers with Mayo Clinic doctors and Stanford doctors, and I had one published today.
Yay!
And that's my third. Today is my third paper, and what I realized is that there was nothing out there to help educate patients. So I thought, what am I going to do? So I published these papers. The first one was a case report on my daughter's treatment. The second one was on a review of everything I could find out there. And actually, when I get I picked the doctors I wanted to be co-authors. And, you give them credit, although one of the papers I was, a lead author. But then the third paper was on what I thought was a cause of her treatment, of her disease. She took an acne medicine, and there's nothing out there. And so dermatologists are continuing to prescribe that, and yet there's no warning to any patient. So I wanted to get that out there. But I'm just going to give one little story about a patient. I read on the internet a 20-year-old who was scheduled for a colectomy, which is part of this disease. You lose your colon and you lose your liver. And she was frightened, and she knew nothing about this treatment as usual because no doctor tells her about it. And she wanted to know from other people who had colectomies, what's it like? What do I expect? And I thought, oh my God. And she was living in Southern California, and in fact going to the same institution that originally prescribed the treatment to my daughter, reluctantly, I might add. And so I contacted her, and she told me who her doctor was, and I wrote to the doctor, and actually wrote to his boss because his boss is the doctor we had seen. And he said, well, I'm sorry, we don't prescribe that drug for ulcerative colitis. And I said, that she does. I said, Bill, she does not have ulcerative colitis. This is a liver-driven form of inflammation. He goes, well, I'm sorry, I think differently than you. And I said, well, that Norway just published a paper saying that this is a connected symptom. And he said, well, that paper is just a paper at this point. But lo and behold, the next day, her hepatologist called and put her on vancomycin. So she is now normal. She has a normal colon, normal liver. But this is just one patient, and there's many of them out there. And so I can't educate everybody. So it's up to patients to really try to get on the internet and discover who are the experts, and then look at what they've published, go to their medical centers, look at papers that they've done, and then pull those papers up. And sometimes you can't pull them up because they're on public med and you have to have some sort of access through a medical institution. But you write to your doctor and say, I'd like to get a copy of this paper.
Can I just add, so what she's kind of saying is she had to build a community.
Yes,
She didn't get to find it, she sort of created
I've
it.
built it. And
She's also like done this thing where she has figured out like how the doctor's email addresses are,
yes.
created. So she's done.
But it really helps keep this work going in a way that's organic and not just these individual activities that don't have a relationship to each other. And so I hope that through this and through these 2.5 days, that you'll start to see some of the threads, and you'll see which color thread or color threads you are. Ashley has on 3 or 4 colors today, so she's multiple color threads. And where you can weave yourself, where you find yourself weaving in and looking at different points of entry. So I'd like to see if anybody has questions. We've got about 5 minutes before I turn this over to colleague Melissa Williams. Yes.
About the resources that would have helped her. And I would say they have been so many times.
Yeah.
We depend on the social work network. We depend on case managers to know everything and to really plug people in, which always doesn't happen. And that's why I like what Ms. Cynthia said. Yeah. You have become real radical for a reason, and it works. That's great. And so my question is, since you saw that in action, what have you changed as far as your implementation of being advocate, especially in a hospital setting where you are?
Sure. Well, I'm in the hospital pretty much once a week, sometimes multiple times that week, and I become a patient advocate by talking to. I'm really an introvert, I guess, but when it comes to people who need me and I see that need, I tend to reach out to where maybe I wouldn't otherwise. But I do give them the information. I have cards with PAF. I have my NPAF cards, but I have PAF with the number And so multiple people that I've talked to in the doctor's office and in the chemo infusion room, I've given them that information, and I just, wherever I am, I have this ear and I'll listen, like be on the airplane. I travel a lot, and it's just like wherever I go, I just trying to spread that information, the resources, and let them know. But we need more patient advocates in doctors' offices, patient navigators, because there's only so many nurses, there's only so many doctors, and they're really super busy, and there's a large influx of people who, are sick, and there's just not enough people to go around. And I think if we could put more people that have empathy in these positions, that they'll reach out more, so.
Great. Yes.
As a newer advocate, I have kids working in a healthcare organization. I'm a patient myself, and I have a child that's also a patient. So I kind of play wear different hats at different times. But what advice would you give to someone that is starting out and really wants to hit the ground running? Do you have any suggestions or one things that you would recommend that they start over somewhere else?
This is a good place to start. I would say that just talk to as many people here as you can, especially people that have been here for a long time, that have kind of been through that, have a lot of resources themselves. For me, it was reaching out to other people in my community and being a part of that community and seeing what kind of needs were not met. And if you have a child that has issues that they're going through, that they're being treated, to just have that ear when you're in the doctor's office, or if you're in the hospital, or even at the grocery store. But then resources online, Dr. Google is your friend. Don't WebMD, don't Dr. Google, you know what I'm saying. But there's so many resources on the internet that you can find. But honestly, the best resources you're going to find are the people that are in this room. So.
Great. All right, I think that's an excellent place to wrap up this panel. Ooh, Chris, did you want to say something, or you? Yes.